Thomas.
Thank you. Good morning. Melanoma was I think the first disease for which immune checkpoint inhibitors was approved, starting with ipilimumab, and then as of 2015, anti-PD-1, nivolumab, and pembrolizumab got approved for metastatic disease. And as of 2018, those two drugs also got approved for the adjuvant situation. Both situations, adjuvant and metastatic disease, being treated with checkpoint inhibitors, really revolutionized the outcome of patients. But still, about 50% of patients having advanced disease will succumb from the disease within 5 years of diagnosis from metastatic disease. So there is still an unmet need for patients having failed checkpoint inhibitors for innovative and effective treatments. Now, TIL treatment with tumor-infiltrating lymphocytes, abbreviated TIL, consists of the surgical removal of a melanoma lesion. And then these are then either fragmented or digested and cultured in the presence of interleukin-2 rich medium. And upon initial and sufficient outgrowth, these cells are then rapidly expanded in the presence of anti-CD3 antibodies, irradiated feeder cells, and also interleukin-2 to billions of cells. And these cells are then infused in patients that have received prior lymphodepleting chemotherapy to make physical space for the billions of cells that have been cultured in a period of between 5 and 6 weeks. And following infusion of the cells, high-dose interleukin-2 is administered, mostly 4 or 5 doses to these patients in order to promote survival of the cells that we have infused. Now, there's a lot of evidence that TIL can be quite effective, but these are coming from non-randomized, mostly small to intermediate size phase 1 and phase 2 clinical studies in different areas in the world, mostly academic institutions, but more recently also pharma has produced TIL, and all showing more or less a similar result, that this can be effective, but never a randomized control trial was performed. So we set out in 2014 to start a randomized control trial for melanoma. All of these patients needed to have maximum of 1 prior line of treatment. The majority of these patients, 90%, would have had anti-PD-1 prior treatments. Of course, the disease needed to be measurable. Patient needed to have a good performance status, and the LDH should be normal or up to 2 times upper limit of normal. Then patients that were following screening and were eligible were randomized between TIL treatment or ipilimumab, where ipilimumab was given at a standard schedule with 3 milligrams per kilogram every 3 weeks for 4 doses. TIL randomized patients would, of course, first undergo a metastectomy to receive tumors to grow the TIL, and after 5 weeks, these patients would be hospitalized to receive first chemotherapy consisting of cyclophosphamide and fludarabine, then the infusion of between 5 times 10 to the 9 to 2 times 10 to the 11 TIL, followed by interleukin-2 and follow-up. The primary endpoint of the study is progression-free survival according to RECIST 1.1 per investigator review in the intention to treat population. And these are the outcomes. The study met its primary endpoint with a follow-up time of median follow-up time of 33 months. TIL resulted in a reduction of 50% compared to ipilimumab in the chance of disease recurrence or death. The median PFS time was 7.2 months versus 3.1 months for the patients treated with ipilimumab. When we look at the overall responses in these patients, also TIL was better compared to ipilimumab. In total, 49% of patients had an objective response. 20% patients had a complete remission compared to 21% of patients having a response in IPI, and 7% of these having a complete remission. When we look at the waterfall plots, about 70% of the patients had clinical benefit following TIL versus 40% of the patients with ipilimumab. So I want to summarize already. So this is the first multi-center randomized controlled trial studying in T-cell therapy in a solid cancer. In this case, comparing TIL to ipilimumab as a more or less second-line treatment in patients with metastatic melanoma. As I showed you, TIL significantly improved the progression-free survival with a hazard ratio of 0.5 and a p-value smaller than 0.001. TIL resulted in a 49% of objective response rate and a 20% complete remission rate. I didn't show you the results of the safety, but there were no new safety concerns for TIL. As what is known for this treatment, all of these toxicities are driven by the lymphodepleting chemotherapy and the high-dose interleukin-2. Most of these side effects were already completely gone by the time the patients were released from the hospital, and there were no long-term sequelae in patients treated with TIL. There was also a better health-related quality of life score for patients treated with TIL, so we think that TIL could become a possible new treatment option for patients with advanced stage melanoma. I would like to stop here.
Thank you very much, John. And now we can open